The President, moderators, ladies and gentlemen, we now present our results studying sequential staging of univentricular palliation within a single hospitalization. We have no relevant financial disclosures with respect to this presentation. As is well known to this audience, surgical palliation of univentricular physiology entails staged surgical procedures that eventually establish a fontan circulation characterized by passive venous return of blood to the pulmonary circuit. Anecdotally, it appears that there is increasing prevalence of keeping infants hospitalized between the first and second stages of surgical palliation for single ventricle physiology. Such an approach may be driven by medical necessity when complex medical care may not be feasible to be delivered in a domestic situation, or a social necessity when the family situation may preclude safe discharge. In rare instances, such a practice may be driven by a specific programmatic preference. It is currently unclear if such an approach of keeping infants hospitalized is driven by a perceived increased complexity or preoperative risk prior to stage 1 palliation, and whether such an approach is necessarily associated with worse outcomes. We sought to evaluate the practice of sequential staged univentricular palliation within a single hospitalization with an aim to describe the frequency with which this practice happens, the variability of this practice over time and across centers, and outcomes of patients that are managed by such a strategy. To that end, we queried the STS congenital heart surgery database for the time period January 2010 to June 2018, and specifically collected information on patients who fell into one of two scenarios. Scenario 1 included all patients whose primary operation was a Norwood procedure, followed during the same hospitalization by any one of the codes for superior cavopulmonary anastomosis, including, say, hemifontan or cavopulmonary anastomosis with atrioventricular valvuloplasty or pulmonary arterioplasty, etc. Scenario 2 included all patients whose primary operation was the hybrid stage 1 palliation code, such as branch PA bands, ductal stent, or a combination of both, followed again during the same hospitalization by a Norwood procedure. Preoperative characteristics and outcome data were collected and evaluated. We also calculated the proportion of patients who were managed by these kept hospitalized practice over a denominator of all patients who underwent initial Norwood or hybrid stage 1 operation within each center to assess the variability of practice across centers. The primary endpoints of the study are shown here. We studied outcomes, which included database mortality and postoperative length of stay, defined as days from index operation to database discharge. We studied the time interval between the first eligible cardiovascular operation to the second. And we also lastly studied the prevalence of preoperative risk factors as defined for the primary index operation. Standard statistical methodology was used, and here are our results. For scenario 1, 5,880 patients underwent an index Norwood operation during this time period, of whom 417 or 7.1% patients were kept in the hospital until stage 2 palliation. In scenario 2, following hybrid stage 1 in 1,132 patients, 204 or 18% patients were kept in the hospital until subsequent Norwood procedure. In both the scenarios, the numbers of patients who were kept hospitalized through to the second stage increased over the duration of the study. Roughly twofold more patients at 12.3% were kept hospitalized during the 2014 to 18 time period compared to 6.3% patients between the 2010 and 2013 time period. Despite this change, The proportion of patients managed by these staged and kept hospitalized scenarios varies widely across centers, as shown in these histograms. The histogram on the left depicts the range of patients who were kept hospitalized through stage 2 in scenario 1. As can be seen, this percentage varies from 0 to 100% with a median of about 4.1%. To the right of the screen is a histogram for scenario 2, again showing a range that goes from 0 to 100%, but this time the median is roughly around 7.1%, a slight move towards the right. This stacked bar graph shows the same data in a different fashion where each bar represents an individual center and the stacked columns in different colors shows the proportion of patients that fall into the various cohorts of management, such as diseased after stage 1, discharged alive after stage 1, and kept hospitalized through to stage 2. Again, this clearly demonstrates that in scenario 1, there is wide variability of patients who are kept hospitalized through stage 2 palliation. A similar stacked bar graph for hybrid shows the same finding of significant inter-institution variability with this practice. For both the scenarios, patients that were kept in the hospital through to the next stage of palliation had significantly higher risk factors pre-stage 1 intervention. For example, the need for preoperative mechanical circulatory support was 3.7-fold higher in patients who were kept hospitalized compared to those that were not in scenario 1, and 1.2-fold higher in patients who were kept hospitalized versus those who were not in scenario 2. Similarly, mechanical ventilation, renal dysfunction, and shock present at surgery were all more frequently seen in patients who were kept hospitalized through the subsequent stages of palliation. As would be expected, the postoperative length of stay was significantly prolonged in both scenarios in patients who were kept hospitalized through subsequent stage of palliation. Despite this, survival to hospital discharge was not lower in patients who were kept hospitalized compared to the traditional discharge strategies for either scenario. This is particularly relevant considering that these patients who were kept hospitalized had a longer at-risk time period in the hospital and underwent another subsequent surgery as well. This table shows the numerical values for the results I just presented. Again, postoperative length of stay is statistically significantly higher in both scenario 1 and scenario 2, whereas mortality is not comparably different in either scenarios. In conclusion, sequential staging of univentricular physiology during single hospitalization appears to be increasing in prevalence based on our results, although there is wide variability across centers with the utilization of such a practice. Stage 1 patients who are kept in the hospital through to the second stage palliation have a higher pre-stage 1 risk factors and therefore represent a high-risk group of patients. Despite belonging to the high-risk group, survival to hospital discharge is not lower in the patients who are kept hospitalized through second stage palliation, despite having a longer at-risk time frame and having a second stage surgery during the same hospitalization. Based on our results, future studies are required to identify what specific subset cohort of patients are likely to benefit from this strategy of sequential staging of univentricular palliation during the same hospitalization. We thank the Society and the organizers for the privilege of this floor and will take any questions at this time point. Thank you.